is about heart radiology. Heart is a hollow muscular organ of middle mediastinum designed to pump the oxygenated blood around the systemic circulation and the deoxygenated blood around the pulmonary circulation. It's pyramidal in shape and lie obliquely in the chest with a square-shaped base point posteriorly. This is the square-shaped base point posteriorly, and the elongated apex, this is the apex, lie to the left and inferiorly. And the heart lie between the second to the fifth intercostal space with 1/3 to the right of the midline and 2/3 to the left. Relations: anteriorly is the body of the sternum, costal cartilage, left lung, and pleura. Posteriorly, esophagus, descending thoracic aorta, azygous and hemiazygous vein, and thoracic duct. Superiorly, bifurcation of main pulmonary trunk. Inferiorly is the diaphragm, laterally lung and pleura. Heart is composed of 4 chambers, 2 atria and 2 ventricles. The left atrium, this is the left atrium, form the base or the posterior part with the superior and inferior pulmonary vein. These are the red arrows are the pulmonary vein drain into its 4 corners. The right atrium, this is the right atrium, form the right heart border with the superior vena cava and inferior vena cava draining in its upper and lower part. The right ventricle, this is the right ventricle, form the anterior part, and the left ventricle, this is the left ventricle, form the apex and left heart border. This is axial slice CT showing the heart chambers. This is the anterior chamber, is the right ventricle with the right atrium above, and this is the left ventricle, and this is the left atrium. And this is bifrontal chest X-ray. The right heart border is the right atrium, and superiorly we have aortic arch pulmonary trunk and superior vena cava draining in the posterior aspect of the right atrium at the level of third intercostal space. In the left side, we have left atrium and left ventricle with descending aorta and vertebral body lie posteriorly. The oblique orientation of the heart causes the ventricle to lie anterior and inferior to the atria, and the heart is rotated in a clockwise fashion about its axis so that the right atrium and ventricle are slightly higher level than left atrium and ventricle. We have interatrial and interventricular septa between the atrium and ventricles. These lie in the left anterior oblique plane. We have 4 heart valves: tricuspid, mitral, aortic, and pulmonary. The pulmonary is the most anterior and superior of all cardiac valves. The tricuspid valve, this is the tricuspid valve, lie between the right atrium and right ventricle. The mitral valve, this is the mitral valve, lie between the left atrium and left ventricle, and it's composed of 2 cusps, anterior and posterior. The aortic valve allows the blood to exit to the left ventricle. The aortic valve composed of 3 cusps, anterior, 1 anterior and 2 posterior, right and left posterior. Pulmonary valve allows the blood to exit the right ventricle, and it composed of 3 semilunar cusps, 1 posterior and 2 anterior, right and left. The cusp of the pulmonary valve and aortic valve are the reverse of each other. We can use the letter A of the aortic valve for 1 anterior cusp for the aortic valve and the letter P for 1 posterior cusp in the pulmonary valve. The borders of the heart, the right border, this is the right border, formed by the right atrium and superior vena cava and inferior vena cava. The left border, this is the left border of the heart, formed by the left ventricle, left atrium, and pulmonary trunk and aortic arch. The inferior border, this is the inferior border of the heart, formed by the right ventricle. while the superior border, this is the represent the superior border formed by left atrium, right atrium, pulmonary trunk, and ascending aorta. Surfaces of the heart, the posterior surface formed mainly by the left atrium and to less extent by the right atrium. In this lateral chest X-ray, we can see the posteriorly, we have left atrium forming the posterior border of the heart and little by right atrium. The anterior surface, this is the anterior surface formed by the right ventricle inferiorly and right atrium superiorly. The right heart surface is formed by the right atrium, this is the right atrium superiorly and right ventricle inferiorly, while the left surface is formed by the left ventricle and little by left atrium. Inferiorly, this is the inferior surface, both right and left ventricle, and the central tendon of diaphragm. The heart is enclosed in a sac called pericardium, which composed of two layers, parietal and visceral layer. And there is a potential space between them, which contain 20 to 25 ml of serous fluid. The visceral layer adheres to the myocardium, and it's known as epicardium, while the parietal layer is free, except inferiorly, where it bound to the central tendon of the diaphragm, and superiorly, where it fused with the covering of the great vessels. The pericardium extends superiorly for 2 to 3 cm over the ascending aorta and over pulmonary artery almost to its bifurcation. It also extends to a short distance over the vena cava and pulmonary vein. Some fat is present between the epicardium and myocardium, and also between the pericardium and mediastinal pleura, and it's more extensive in anterior and lateral cardiophrenic angle. These are known as the pericardial fat pad, and the amount of this fat increases with increasing age. Here we can see the pericardial fat pad in this frontal chest X-ray demarcated by this white arrow, and this is by axial slide CT demarcated by this red arrow. Pericardial recesses, we have pericardial recesses and pericardial sinuses, which represent small spaces formed by pericardial reflection. Fluid may accumulate here and may mimic mediastinal lymph node, cyst, or tumor. We have two sinuses, oblique sinus and transverse sinus. The oblique sinus is a blind end sac. This is the oblique sinus, which lie behind the left atrium. It occurs between the left atrium, this is the left atrium anteriorly, and the esophagus posteriorly. And it's separated from the other sinus, which is called the transverse sinus, by reflection of pericardium that runs between right and left pulmonary vein. The transverse sinus, this red area represents the transverse sinus. It occurs anterosuperiorly over the left atrium, between the aorta and pulmonary trunk anteriorly to the superior vena cava on the right and left atrial appendage on the left. This is the left atrial appendage on the left. This is aorta anteriorly, and this is the superior vena cava on the right side. And behind we have oblique sinus. The pericardial recesses, we have superior aortic recess. This consists of anterior right lateral and posterior portion. This is the anterior, this is the right lateral, and this is the posterior portion. The anterior portion is the space between the ascending aorta and superior vena cava. This is the ascending aorta and superior vena cava, and this is the anterior portion. Fluid may accumulate here and may mimic aortic dissection. The lateral portion, this is the lateral portion, the right lateral, formed between the ascending aorta and superior vena cava. And we have the posterior portion, this is the posterior portion, lie posterior to the ascending aorta. So this triangular area represents the superior aortic recess. Pulmonic recess lie inferior to the pulmonary artery. This is the pulmonary recess. We have also posterior pericardial recess, which lie posterior to the distal right pulmonary artery and medial to the bronchus intermedius. This is the posterior pericardial recess. The fluid may here mimic the subcarinal lymph node. Pulmonic vein recesses lie along the lateral border of the heart between the superior and inferior pulmonary vein. Postcaval recesses lie posterior and to the right of superior vena cava. This slide demonstrates the difference between the normal pericardial recesses, this is the aorta and pulmonary artery, and the difference between it and this between the enlarged mediastinal lymph node. Normal fluid, the pericardial fluid here, it has fluid density and it's not enhancing, triangular in shape, and it's continuous with other pericardial recesses. By this feature, we can differentiate it from other pathology like enlarged lymph node, cyst, or tumor. This is axial slide CT with contrast showing the ascending aorta, descending aorta, pericardial fluid here, anterior superior pericardial recess, and this is the posterior portion, posterior superior aortic recess. This is also CT with contrast. Here we have the transverse sinus, and this is the oblique sinus. This is ascending aorta, superior vena cava, and descending aorta. Coronary arteries. Aortic valve have 3 semilunar cusps, as I mentioned before, 1 anterior and 2 posterior, right and left. Above each cusp, there is a localized dilatation known as a sinus of Valsalva. The original or coronary artery originates from these sinuses. The right coronary artery arises from the right anterior sinus, while the left coronary artery arises from the left posterior sinus. No coronary artery arises from the right posterior sinus, and this is known as a non-coronary sinus. Here we can see this is the aortic valve. This is the origin of the right coronary artery from the right anterior sinus. This is the origin of the left coronary artery from the left posterior sinus, and this is the non-coronary sinus, which is the right posterior sinus. This is by echocardiography demonstrating the coronary cusp. Here, this is the anterior or the right coronary cusp. This is the non-coronary cusp, the right posterior, and this is the left coronary cusp, which is the left posterior cusp. The right coronary artery supplies the right ventricle and inferior wall of the left ventricle. It runs to the right between the pulmonary trunk and right atrium to descend in the right atrioventricular groove as a marginal artery. On the inferior surface of the heart, it anastomoses with the left coronary artery in the region of posterior interventricular groove. The branches of the right coronary artery. We have conus branch to the pulmonary outflow tract. This is the conus branch. Atrial and ventricular branch. This is the ventricular branch. We have acute branch to the SA node, and we have acute marginal branch and branch to the AV node. This is the atrioventricular or AV node branch. And lastly, we have posterior interventricular artery, which runs anteriorly from the terminal part of the right coronary artery in the posterior interventricular groove. This is the posterior interventricular artery in the posterior interventricular groove, and at this side it anastomoses with the left coronary artery. The left coronary artery arises from the left posterior sinus of Valsalva, and it supplies the remainder part of the left ventricle. It arises as the left main and passes behind and to the left of pulmonary trunk to reach the left part of atrioventricular groove. This is the main trunk of the left main pulmonary artery before dividing into branches. It bifurcates into 2 main branches. the left circumflex artery, which continue laterally in the atrioventricular groove to anastomose with the right coronary artery. This is the circumflex artery, continue laterally in the left atrioventricular groove. And the other branch is anterior descending artery running into interventricular groove. This is the anterior interventricular or descending artery in the anterior interventricular groove. Each of these branches give other branches. The anterior descending artery give septal branch and diagonal branch and sometimes branch to the right ventricle. And left circumflex branch give obtuse marginal branch and atrial branch. In summary, the right coronary artery supply the right ventricle and inferior part of the left ventricle, while the left coronary artery supply the remainder of the left ventricle. The interventricular septa, which lie between the right and left ventricle, supplied by left coronary artery anteriorly and right coronary artery posteriorly. And we have a papillary muscle which attach the mitral valve to the tricuspid valve and mitral and tricuspid valve to the wall of the heart. These have a different supply. Anterolaterally, the papillary muscle supplied by left anterior descending and left circumflex artery. So it have a dual supply, and this make it resistant to ischemia. While posteromedially, the papillary muscle have only one supply from posterior descending artery, and this make it more liable for ischemia and subsequently mitral regurgitation. This is left coronary angiography demonstrating the left main coronary artery dividing into left anterior descending artery and left circumflex artery. The left circumflex artery give obtuse marginal branch, and the left anterior descending give diagonal and septal branch. This is axial slice CT with contrast showing this is the aortic valve, this is the right coronary artery originating from the right anterior sinus of Valsalva. And this is the branches of the left coronary artery, the left anterior descending artery, and left circumflex artery. We have what we call coronary dominance. By coronary dominance, we mean which vessels supply posterolateral aspect of the left ventricle. We have three types of dominance, either right dominance, left dominant, or codominant. The right dominant, this is the most common type, represented by 60%. In this case, the right coronary artery give the posterior interventricular branch and continue around the atrioventricular groove and give branch to the posterolateral wall of the left ventricle. The left dominant, in which this situation, this is least common type, only 15%. The right coronary is short and the left circumflex supply the posterolateral wall of the left ventricle and give off posterior descending artery. And we have a codominant in which both right and left ventricle, right and left coronary supply the posterolateral wall of the left ventricle, and this is represented by 25% of the cases. The cardiac vein, the venous drainage of the heart, mainly is through the vein that accompany the coronary arteries, which drain into the coronary sinus. This is the coronary sinus, which is located in the posterior aspect of the atrioventricular groove and drain in the posterior wall of the right atrium. This is the right atrium. The main tributaries of the cardiac vein, the first one we have great cardiac vein. This is the great cardiac vein. This ascends in the anterior interventricular groove and pass to the left laterally to drain into the coronary sinus. We have middle cardiac vein. This is the middle cardiac vein run in the posterior interventricular groove. So interventricular groove, anteriorly we have great cardiac vein and posteriorly we have middle cardiac vein. We have also small cardiac vein which accompany the marginal branches of the right coronary artery of the inferior surface of the heart and run posteriorly in the right atrioventricular groove and enter the right side of the coronary sinus. This is the small cardiac vein enter the right side of the coronary sinus. In the left side, we have great cardiac vein enter the coronary sinus. We have left posterior ventricular vein. This accompany obtuse marginal branches of the left coronary artery running up the posterior aspect of the left ventricle and drain into the coronary sinus. And lastly, we have the anterior cardiac vein. This drains the anterior surface of the heart and anterior wall of the right ventricle. This is the anterior cardiac vein on the anterior surface of the right atrium. Radiology of the heart, we have different modalities to evaluate the heart, starting by the chest X-ray. In the chest X-ray, we can obtain two information, first about cardiothoracic ratio and second about the position of the valve. The cardiothoracic ratio is measured by dividing the internal diameter or horizontal transverse cardiac diameter with horizontal transverse thoracic diameter. The normal value in the adult up to 50% and in the children or in the infant up to 60%. And this preferred to be measured in the PA film rather than the AP film because of the magnification of the heart occur in the AP film. Second, we have the position of the valves. The valve lie close to a line drawn from the left atrium. We have in the frontal chest X-ray a line drawn from the left atrium to the most inferior part of the right heart border. And in the lateral chest X-ray from the T5 thoracic vertebra to the cardiac apex. The pulmonary and aortic valve lie above this line, while the mitral and tricuspid valve lie below this line. This is again the position of the valve in frontal and lateral chest X-ray by a line drawn from the left atrium, the left atrial appendage to the most inferior part of the right heart border. Pulmonary and aortic valve lie above this line, mitral and tricuspid valve lie below this line. The second modality we have fluoroscopy. The heart and its valve may be assessed by fluoroscopy. If the valves are calcified, usually pathologically, may be distinguished by their characteristic motion as well as their location. The aortic valve has to and fro motion in the plane of the ascending aorta that's upward, backward, and to the right. The mitral valve has a circular to and fro motion in the left anterior oblique plane of the left atrium and ventricle. Echocardiography uses ultrasound to image the heart. We can obtain information about the cardiac valve and chambers, and we have a transesophageal echocardiography which allows closer inspection of the heart because of close opposition of the left atrium to the anterior wall of the distal esophagus without intervening air or lung. Here this is the four-chamber view of the heart by echocardiography. This is the right ventricle, this is the right atrium, the tricuspid valve in between. This is the left ventricle, the left atrium with the mitral valve in between. This is the interventricular septa, and this is the interatrial septa. This demonstrates pericardial effusion by echocardiography and by axial scan, CT scan. This red arrow represents the pericardial effusion, and here this is the pericardial effusion. Coronary angiography is another modality to assess the coronary vascularity by injection of selective catheterization of the coronary artery and injection of contrast media to show the anatomy of the coronary vessels. This is example of coronary angiography. This is the right coronary artery. This is the left main coronary artery dividing into left anterior descending and left circumflex artery. CT scan show the heart and vessel in cross section. The pericardium appear as a linear density identified between the epicardial and mediastinal fat. Contrast-enhanced CT have advantage for demonstration of the cardiac chamber and vessels, and non-contrast CT have advantage for demonstration of coronary calcification and atherosclerosis. Since the heart is a moving organ, to decrease or to overcome the motion artifact, ECG gating technique used along with use of beta blocker to decrease the cardiac beat less than 70 beats per minute. And also we have sublingual nitrate given to produce coronary dilatation. This is axial slice CT. In different view, we can see this is the CT with contrast. This is the ascending aorta. This is the descending aorta, main pulmonary artery dividing into right and left pulmonary artery, and these are the left superior pulmonary vein and right superior pulmonary vein, and this is the superior vena cava. This is the left atrium. This is the aorta with left main coronary artery arising from the left posterior sinus of Valsalva. This is the right ventricular outflow tract. This is the left atrium with aorta, and this is the origin of the right coronary artery from the right anterior sinus of Valsalva. These are the branches of the left coronary, left anterior descending and left circumflex. This is the right ventricular outflow tract, and this is the right atrium. Again, this is the aortic valve. This is the right atrium, right ventricle, and left atrium. This is all chambers. We can see here the right atrium, right ventricle, left atrium with mitral valve in between. And this, only in this slide we can see two chambers, the right ventricle, left ventricle, and the right coronary artery and left anterior descending artery in the anterior interventricular groove, and right coronary artery in the atrioventricular groove, right side. This is coronal scan with contrast showing the anatomy of the heart. This is the right atrium, left atrium, the apex formed by the left ventricle. Superiorly, we have pulmonary trunk, superior vena cava, and aorta. And also this is axial slide, CT with contrast showing the pericardium, which appear as a thin dense line. This is the pericardium, should be less than 2 mm. And this is the epicardial fat pad, and this is the paracardial mediastinal fat. And this is the right ventricle and left ventricle. Cardiac MRI used for assessment of complex congenital heart disease, evaluation of the cardiac mass, pericardial disease, and cardiomyopathy. Pericardium in the MRI appears as a thin dark line. This is the axial MRI, axial slice. Here we can see the right ventricle, the right atrium. This is the left ventricle with interventricular septa between two ventricles. We have radionuclide study, which used for diagnosis of and assessment of extent and severity of myocardial ischemia, assess prognosis, pre and post angioplasty and bypass surgery. We have two radionuclide agents, technetium-99, methoxyisobutyl isonitril, and thallus chloride 201. And lastly, we have PET CT scan. The normal cardiac muscle concentrate or consume 18-fluorodeoxyglucose, reflecting the normal pulsality and cardiac muscular contraction. Targeted cardiac PET and CT scan allow the detection of metabolically inactive site of infarcted muscle when combined with CT coronary angiography. It may show areas of salvageable hibernating myocardium, which show persistent metabolic activity despite the loss of vascular supply demonstrated at CT angiography. This is the PET, combination of PET, CT, with CT scan. This is the normal cardiac uptake of 18-fluorodeoxyglucose, while this is the abnormal uptake by the right paratracheal lymph node. Thanks for your attention, and if you have any question.
شكرا جزيلا دكتورة كازان. Very nice presentation and nice images. اكو احد عنده سؤال قبل ما نروح على الكويز؟ ماكو، اذا نروح على الكويز. نختار محمد مهدي.
نعم أستاذ. رقم 1 هو البريكارديوم.
نمبر 1 البريكارديوم. نور محمد جواد.
نعم أستاذ. رقم 2 هو الرايت فنتريكل.
الرايت فنتريكل. اوكي. بعد نور احمد خليل.
نعم أستاذ. نمبر 3 ليفت فنتريكل.
ليفت فنتريكل. عقيل. نمبر 4.
نعم أستاذ. interventricular septum.
شنو هذا الفحص عقيل؟
أستاذ سيتي. coronal CT.
كورونال هذا اكزيا. اكزيا CT of through the heart، مو صحيح؟ دعاء على نمبر 5.
نعم. This is thoracic descending aorta.
descending aorta. excellent. نمبر 6 اخير واحد حيدر كريم.
نعم أستاذ. رقم 6 الأسوفيغاس.
This is the esophagus. اكو بعد لو بس هاي؟
لا أستاذ أكو بعد.
يعني بعد بهذه ارقام. استاذ محمد موجود؟
عين استاذ بعد وياك.
يلا تفضل استاذ محمد، تفضل.
محمد مهدي.
نعم أستاذ. رقم 1 هو الليفت مين كوروناري ارتري.
نعم. مريم خليل.
نعم أستاذ. نعم أستاذ.
رقم 2.
رقم 2 left anterior descending artery.
عمر فهمي.
نعم أستاذ. نمبر 3 سبتال برانش.
علي حسين. رقم 4.
نعم أستاذ. هذا diagonal branch. first diagonal branch.
شيماء علاء.
رقم 5 second diagonal branch.
زهراء صباح. رقم 6.
نعم أستاذ. It's a continuation of left anterior descending artery.
رشا داخل.
نعم أستاذ. 7 circumflex artery.
رنين. رقم 8.
رقم 8 obtuse marginal.
ورقم 9 سادي عبد الرضا.
نعم أستاذ. second abtus marginal artery.
ممتاز. خلاص.
اي هاي. شكرا جزيلا عاشتي دكتورة